Behind every compulsion is someone trying to stop. We've talked about what pornography addiction looks like. We've looked at how to treat it, but who's actually walking through the door? And more importantly, what makes the biggest difference once they do? Let's start with the data. Studies show that people who self-identify as having problematic pornography use are more likely to be male, heterosexual, and aged between 20 and 40. Many have tried and failed to stop on their own. Some are in relationships, others are single and isolated. A significant proportion report comorbid anxiety, depression, or symptoms of ADHD. But here is what stands out. Almost everyone reports shame. It is the silent barrier to seeking help. People fear being judged by clinicians, by partners, sometimes even by themselves. For many, seeking help feels like a moral failure, not a health issue. That shame is worsened by the fact that pornography addiction still isn't officially recognized. Patients feel like they're struggling with something invisible, and when they do reach out, they are often met with either confusion, minimization, or even worse, dismissal and judgment. This mismatch between patient experience and clinical response is one of the biggest gaps in care. So who actually does seek treatment? In practice, it's often people whose porn use has collided with another life domain: relationships, work, sexuality, and sleep. Sometimes they've been caught, other times they just can't live with the internal discomfort anymore. They feel out of control. Their values and their behavior no longer match. Interestingly, a number of studies have pointed out the role of moral incongruence. This refers to the tension between someone's personal values and their behavior. It doesn't mean the behavior is clinically disordered, but that the distress is still nonetheless real. That distress often leads people to self-label as addicted, even if their usage patterns wouldn't qualify as compulsive from a clinical standpoint. Still, it's a flag. Whether or not someone meets criteria, it is the impact that matters. So what helps? First, validation. For many patients, just hearing a clinician say, yes, this is a real problem, and no, you're not broken, is the first moment of relief. It breaks the shame loop. It opens the door to treatment. Next, a clear plan. Vague support doesn't help someone stuck in a compulsive cycle. They need structure. That might be CBT, it might be ACT, but it has to be something that moves beyond just try not to watch. And then accountability. In one qualitative study, people in recovery reported that what helped most wasn't a specific technique, it was being seen, being asked, being followed up. Progress isn't always linear. Relapse is common, but when someone feels connected to their clinician, they're more likely to keep trying. Peer support can also be powerful, whether through group therapy, online forums like Reboot Nation, or community meetings. Patients often feel less alone when they hear their own story told by someone else. It creates perspective, it challenges catastrophic thinking, it restores agency. Another under-discussed tool is tracking. Many patients benefit from mood porn use journals, trigger logs, or even basic habit trackers. It gives them data and it replaces shame with information, and over time it builds insight. So they might find themselves saying, oh, I watch more when I'm anxious, or weekends are the hardest. That knowledge helps people plan, not just react. But treatment isn't just about what we give. It's also about what we remove. We should remove judgment, pathologizing, assumptions about why someone watches porn or how much is too much. Some people in treatment will want abstinence. Others want moderation. Your job isn't to set that goal, it's to help them reach their goal. Let's also talk about barriers. Many patients never get to a specialist. GPs might not ask. Mental health services may not be trained. Therapists may avoid the topic altogether. In some countries, insurance doesn't cover it. In others, even naming it could lead to professional or legal consequences. And then there's culture. Religious beliefs, community expectations, masculinity norms, all of these can increase shame, reduce help seeking, or worsen emotional fallout. Clinicians need to understand these layers. So what actually helps people recovery? Well, here's what research and clinical experience suggest. Number 1, self-awareness, recognizing the pattern and its impact. Number 2, non-judgmental clinical support, someone who listens and understands. Number 3, structured interventions, therapy, tracking, behavior change. Number 4, peer connections, shared stories, accountability. Number 5, time. Most people don't improve overnight, but with support, many do. And lastly, language matters. When we say porn addict, we risk defining someone by their worst behavior. When we say problematic porn use, we describe something they want to change. That's the shift that makes treatment possible. So if you're a clinician, ask the question. If you're the patient, know you're not alone. And if you're both, build the kind of space where recovery is possible. Because even without a diagnosis, the need is real. That's all for today, folks. My name is Dr. Ferghal Armstrong, and this has been Cracking Addiction.